Okay. All right. So, couple of rules of the game. As soon as you enter, please make sure you keep your microphone on quiet mode, mute mode, so that we can all, we can all discuss and we are not disturbed when we are discussing. Okay. So everybody, try to put your microphone onto mute mode. I'm just taking a couple of minutes more so that more people can join. But most important is make sure your microphone is on mute mode, okay? Otherwise, everybody gets disturbed. The recording thing on here. Okay, so today we're going to talk about Empyema. Yeah, I'm going to try. It's a very routine topic which we all know a lot about, but it is important for us to discuss because in the exam, I think you will definitely have at least one, if not more, cases of Empyema. So the discussion will happen in one or two areas. Most likely you might have it as a long case, or you might have it as a short case, or you might get it on the Viva table. And also in theory, you can be asked about it. So today I'll try and discuss about Empyema. I'll try and ask you a few things so that we make it all clear what is what, okay? So this is my beautiful hospital where we work, Medanta the Medicity, and of course Bartholomew's Hospital in London. So I am in London at the moment. I came back only yesterday from Taiwan, and we had the Asia Pacific Society of Respirology, and that's where I gave this talk. So I thought it's a good time for me to discuss it with you. But I've added a few more things because you're exam-going students, so I'll try to discuss a few. Pleural infections are very common and they are very old. They have been described even in Greek mythology. So, we're talking about thousands of years ago. People have actually, hundreds of years ago, people have described chest infections. The problem with pleural infection is that they cause a lot of morbidity and they cost the healthcare a lot. So there is a paper out there which says that on average, per year, the cost patients cost to the healthcare is about 320 million. Can I just request everybody to switch your microphone off, please? Somebody's microphone. Just make sure all your microphones are switched off. Somebody's microphone is on. CVTS GMC. CVTS GMC, your microphone is on. Can you switch it off, please? Okay. So, as I said, there is huge amount of morbidity and a lot of mortality. Different papers are quoting different things. There are some papers which are quoting a mortality of 6%. Some papers are quoting a mortality of 20% with an average of about 16%. Now, everything that I'm stating today is actually backed by a paper. So every single line on the slide is actually, there's a paper associated with it. So you can safely quote this in the exam and nobody can challenge you, okay? So just stay rest assured that everything that I've put on this slide is part of literature. So what are the common organisms that we see, okay? Most of the empyemas that we see in our clinical practice are parapneumonic effusions, which get converted into empyemas. So you get a chest infection and you get a chest infection and then you get subsequent invasion of the pleural space by the bacteria, and that gets converted from a simple pleural effusion to a empyema. So the various organisms that you will see are Streptococcus pneumoniae, S. pyogenes, Staphylococcus aureus, S. anginosus. Okay, these are the 3 or 4 that you must remember when you're asked in an exam. These are the common organisms that you'll see which cause chest infections and subsequently can cause empyemas. So Streptococcus pneumoniae, Streptococcus pyogenes, Staphylococcus aureus, and Staphylococcus aureus, as you know, is something that is present on the skin. So it's a commensal on the skin and it becomes an opportunistic infection. And then there's a group of organisms which are called as S. anginosus. And under this, there are many unusual organisms. You don't need to remember all. Okay, again, I need to tell you to switch off your microphone because somebody's microphone is booming back and we can hear it. Now, one of the common things that is happening in the UK and also in India, unfortunately, it's not reported as much as in India, is the onset of community-based infection. So we do see a fair number of MRSA, enterobacteria, and anaerobes. Okay, so MRSA usually is a real tricky problem because these are resistant to standard treatments and they increase the mortality quite dramatically. So it's important that we treat things according to sensitivity so that we do not create antibiotic resistant organisms. Okay? All right. So in India, in addition to all this is seen, but the challenges are more. We have the challenge of tuberculosis, and you guys work in National Institute for TB, and you know that it's a big, big problem. Not just TB, but nowadays we are facing with MDR TB and also XDR TB. So these are all real issues, and they're costing the healthcare of the country dramatically, a lot. And that's why we have to take these problems very seriously. Okay. This is just to let you know that I get repeatedly told by my cardiothoracic colleagues that thoracic surgery is a poor man's disease. Okay, something like this. And they are under the impression that cardiac surgery is all very posh. Okay. Now, these are my two kids. Obviously, they're not as small as this now. My son is about 16 and my daughter is about 13. So, but they are very posh. So the cardiac surgeons always believe that they do all very posh stuff. But that is not true anymore because infection has become more and more endemic. The population is traveling a lot more. And I personally have seen, corporate CEOs who come with empyemas or with tuberculosis. I've operated on people who are very rich and very affluent businessmen and come from well-to-do families. I've seen young children from very, very good families who are suffering with empyema. I'm recently treating somebody who has unfortunately been diagnosed as MDR TB, and that's from a royal family. So can you imagine that TB and chest infections are now getting more and more endemic, and we really got to take them very seriously. So let's get down to the theory of it, and then we'll talk about the treatments that we have. Okay. So what is the role of imaging? I think the most important investigation in empyema or pleural infection is a chest X-ray. It's a cheap, very effective investigation, which gives you quite a good picture of what is happening in the chest. So a chest X-ray is mandatory. If you order a CT without doing a chest X-ray, I think that is unpardonable. Okay, so chest X-ray is a very, very good investigation. Now, more and more, there is role of ultrasound in the evaluation of the chest. In fact, so much so that in the UK, with regards to the BTS guidelines, you are actually not allowed to put in a chest drain, whether it's a center or whatever. You're not allowed to put in a chest drain without using a pleural ultrasound. It's legal and it's mandatory. So nobody can, deny the role of ultrasound. It's become very, very important. A, it helps you to quantify the amount of fluid. B, more importantly, it tells you whether there are loculation present or not present. And C, it also gives you an indication of the state of the lung. Because very often on a chest X-ray, you see an opacity and you think that is fluid. But when you put in an ultrasound, it shows you collapse, consolidation of the lung. So you may not need to put in a chest drain. So I think an ultrasound is quite a good investigation to give you further details that you've seen on a chest X-ray. But an ultrasound is only as good as the operator. And my suggestion to all you young guys is that start using the ultrasound. You have these Dopplers available around the hospital. Every time you want to put in a chest drain, before you do that, put the Doppler on the chest and get used to what the lung looks like and what fluid looks like and what are the ways to get various windows. So I think an ultrasound is a good tool to have in your hand. and it's pretty cheap. It doesn't cost you much to get an ultrasound done. A CT scan remains a gold standard, and very often we keep getting asked, what kind of CT do you want? To be really honest, if I'm going to be operating on the patient, I want a CT. But if I only want an assessment of the lung and the pleural space and the chest wall, then I'll ask an HRCT. Particularly for the lung, it gives me additional information. But most of the times in our setup, we'll end up doing a CECT because we are going to be operating and we want to make sure there is no thrombus, no pulmonary embolism and things like that. Because these things can get picked up, particularly in chronically ill patients. Now, there are a few newer investigations available in the market, and we'll discuss the role of each one of them. MRI, I'm going to talk about in a minute, so just stay with me with the MRI. I don't think PET has a huge role in management of empyema per se. So it is not an investigation of choice in the investigation for empyema. However, PET does come into its own when you're dealing with empyema secondary to malignancy. So in malignant effusions which become infective, a PET may actually help you to look for distant metastases. So rather than helping you with what's happening in the chest, it will help you look in the rest of the body. So this is a trick question that they sometimes ask you in the exam, that do you think PET has any role in empyema? The answer is no. It has no role in the diagnosis of empyema, but when you're dealing with a malignant empyema, then PET helps you to look for pathology elsewhere in the body. Because sometimes you might have to put in a needle biopsy, and instead of in the chest, you might find a small lymph node in the supraclavicular area, and that is much more easily accessible. So PET has only a role in that sort of a scenario. Okay. Thoracocentesis, again, I'll talk about it in a minute. So thoracocentesis has its role, and we'll discuss it in a minute. So let's look at MRI. Now, MRI, we know, is quite an extensive investigation. Cost is involved with MRI. But the good thing about MRI is it is magnetic. So there is no radiation involved in this. Okay. And somebody's dog is barking. Is that correct? Somebody's dog is barking. Can you just switch off your microphone or get away from the dog? I don't know what to do, but there is a sound of a dog in the background. So anyway, MRI has been known that using simple MRI of the chest, you can actually tell the difference between a transudate and an exudate, because an exudate gives you higher signal in T1 and T2 images. And particularly when you're dealing with people who have a contraindication to CT scan, like a young pregnant female, you know, the last thing you want to do in a young pregnant female is expose her to radiation. In that sort of a scenario, actually MRI might be helpful. Also, in patients whom you think you will need repeated CT scans, in that sort of a scenario, an MRI may be superior because the amount of radiation that you give to the body is less. But of course, MRI is a much more cumbersome investigation because it takes 30 to 40 minutes to get an MRI done. And a lot of people get very claustrophobic when they go through that MRI tunnel. And also, people with chest infection may not be able to lie down flat for the MRI to happen. So these are the contraindications or problems with an MRI. So you must know this when you answer in an exam. So if an examiner asks you, would you do an MRI? You should say, not as a routine, but only in specific instances would I do an MRI. Okay. Thoracocentesis. Thoracocentesis means putting a needle into the chest and aspirating some fluid. So there are two types that you can do. One is, of course, for diagnostic purpose, and the second one is for therapeutic purpose. Usually the standard guidelines that say that you should do thoracocentesis is that in a chest X-ray on a CT scan, at least more than 10 mm of fluid should be visible, in terms of a chest X-ray. In cases of chest trauma or in the presence of sepsis where you're worried that there's acute sepsis in the patient, it's well worth doing a thoracocentesis in the chest. A, to get pleural culture, B, to get pleural biochemistry, and C, to get pleural cytology. So these are the three indications: pleural culture, pleural biochemistry, and pleural cytology. All three of them give you specific information, and we'll discuss that in a minute. The most important thing that you have to remember is no longer is it legally acceptable for you to do a thoracocentesis without the use of ultrasound. In the UK, absolutely categorically, it has been said that you have to use an ultrasound while doing the procedure. Not that you send him down for ultrasound, somebody puts a cross mark, and then he comes back and you put in a needle. That is a very ineffective way of doing things, because when you put a cross on the skin, the cross can move, the skin can move, the patient may take a deep breath and things like that. So the correct guideline is that you must do an ultrasound with your left hand and a needle in your right hand. So under the ultrasound guidance, the needle must enter the chest. And the reason for doing this is that you will be surprised, but being a thoracic surgeon, I have seen that thoracocentesis needle go into every single organ that you can talk about. I have seen it hit the spleen. I have seen it. I haven't done it, but I've solved the problem when other people have put in needles into the spleen, needles into the liver, diaphragm, stomach. I've even salvaged needles in the left ventricle. I promise you, I've seen a needle go through the left ventricle while somebody was doing a procedure. So it's not without its risks, and there's a risk of mortality of about 1 to 2%. And even senior surgeons have done it, and I have had to come in and salvage the situation. So an ultrasound guided procedure is the only way that you can make sure that it is safe. Okay, so skin marking is not enough, and this is part of NICE guidelines. So in the exam, when the examiner asks you, what about thoracocentesis, you must say it should be done as an ultrasound guided procedure. It's very, very, very important. Okay, all right. What about pleural fluid biomarkers? Now, at this stage, I'm going to take the opportunity to talk about what is an exudate and what is a transudate, because this is required for the exam. So let's look at what is an exudate and what's a transudate. So let's start with the transudate first. A transudate is something that has got low protein content, okay? And the pulmonary capillarity is normal. So this is usually an area and a phenomenon where the protein content of the body has gone down. So we are talking about, cachectic situations. So left ventricular failure, in cases of cirrhosis, in patients with hypoalbuminemia, atelectasis, renal failure, peritoneal dialysis, pulmonary embolism, mitral valve disease, or constrictive pericarditis. So these are some of the conditions which will give rise to the fluid moving out of the vascular channels into the pleural space and getting accumulated there because the protein level in the body has gone down. On the other hand, exudate has got high protein content. And this is usually because there is some sort of inflammatory process going on. So here, there is damage to the pulmonary capillarity. The lining of the pulmonary capillarity is damaged because of the inflammation, because of the infection, as a result of which fluid will escape from within the vascular channels into the pleural space and not move back in because the capillaries become leaky, as we say. Okay, so the pleural biomarkers that suggest that there is infection is a pleural pH of less than 7.2. This is an important factor. Now, one thing that you have to remember is that a pleural pH of the fluid that you take out can be changed by a lot of things. A simple thing like using lignocaine into the skin before you put in the needle can actually change the pH of the aspirate. Or you have aspirated air along with that fluid, that can change the pH. Or you have used some sort of a chemical sterilizer on the skin and that got aspirated. So a simple litmus test to look for pH of that pleural fluid is not adequate. And the recommendations of the BTS guidelines is that you must use a blood gas analyzer. And when on a blood gas analyzer, the pleural fluid comes back as pH of less than 7.2, it is fairly diagnostic that you've got infection going on and you're dealing with empyema. Another factor that you have to look at is the fluid glucose. And fluid glucose less than 40 milligrams per deciliter is an indicator that there is something going on there. The third factor is pleural fluid, pleural protein, which should be more than 2.5 grams per deciliter, or LDH of more than 1,000 international units per liter. Now, there are a lot of factors in the pleural fluid that people look for, but these four you must know, okay? So I'm going to repeat it for the sake of understanding it. So number one is a pleural fluid pH of less than 7.2, a fluid glucose less than 40 milligrams per deciliter. The US say less than 30 milligrams per deciliter, doesn't matter. It's more or less a low fluid glucose. A pleural fluid of a protein of more than 2.5 grams per deciliter, and an LDH of greater than 1000 international units per liter. Okay, this is important, these four factors. Besides this, there are things like a presence of white cell count of more than 5000 in the fluid and things like that. That's not so important. These four are the important criteria for defining it as an empyema. So there is something called as Light's criteria. You will be asked in the exam, what are the Light's criteria for calling the pleural fluid as an exudate? Okay, and you must know this. There are only three factors you must know. The first one is a pleural versus serum protein greater than 0.5, a pleural versus serum LDH greater than 0.6, and an LDH level more than 2/3 over the normal upper serum level of LDH. So remember this. So I just come back to the previous one. So pleural pH, pleural glucose, pleural protein, and LDH. And the Light's criteria for calling it an LDH is comparing the pleural versus the blood level, the serum level of proteins. And this comparison has to be more than 0.5. A pleural level versus serum LDH has to be more than 0.6. Both of this suggest that there is raised pleural protein and there is raised pleural LDH. Okay, normally it's not high. So if you've got these numbers coming up as high, it means there is an exudate going on. And an LDH, that means a raise in the LDH level of more than 2/3 over normal upper serum level, okay, of LDH. So this is important. You will be asked in the exam, either in the viva or in theory as well. You can get this in theory as a short note. Discuss empyema and discuss Light's criteria. Okay, and the pulmonologists love to ask you these questions. Okay, so what can cause an exudate? We looked at what can cause a transudate. Anything which causes low amount of proteins in the vascular spaces causes a transudate. So what can cause high proteins in the vascular spaces? You can get a pulmonary embolism with infarction of the lung. You can get a parapneumonic effusion secondary to infection. You can get tuberculosis. We know that very well. You can get benign asbestosis, which can cause an exudative effusion. You can get inflammatory diseases and immunological diseases like SLE and rheumatoid arthritis. Pancreatitis can cause an exudative effusion. In fact, one of the diagnoses of knowing that you're dealing with pancreatitis is to look at pleural amylase level. And if it is elevated, then the cause of this exudate is pancreatitis rather than the chest. Okay. Esophageal rupture can cause it. Dressler's syndrome, post-cardiac surgery, post-pericardiotomy, you can get Dressler's syndrome, and that can cause an exudative reaction, or chylothorax. Okay, chylothorax can also cause an exudative reaction. So all of this, if you look at them, these are either inflammations or infections. Okay, so the easy way to remember, exudates happen because of inflammation or infection. Transudates happen because of hypoproteinemia. Okay, so that's one good way to remember the difference between the two. Now, looking at the literature, there are many papers who are looking at new pleural fluid biomarkers. They have looked at TNF alpha. They've looked at myeloperoxidase. They've looked at C-reactive protein. They've looked at procalcitonin. And many papers are looking at these new ones. But the bottom line is, none of them so far have been superior to a pleural fluid pH and glucose. Okay, so at this moment, the gold standard still remains pleural pH and glucose. Simple test, but it gives you a lot more information. And all these complicated biomarkers have not really given you any further information than what you already have. So I think you just need to know what are the new pleural fluid biomarkers. Maybe in future they will be more of use. But at this moment, none of them have any data suggesting they are better than the others. So that's one thing. We've done the biochemistry of the fluid. Now the question occurs, what about the microbiology? So whenever you take the fluid, there are three things you have to do, very, very important. One is the biochemistry of the fluid. The second is the microbiology of the fluid. And the third is the cytology of the fluid, okay? So it's quite important. And for any of these things, what you need is volume. So don't just take 2 ml, 5 ml fluid and send it away for all these tests. That's no good. Microbiology, it's okay. You'll be able to get quite a decent number with a few ml of quite a decent culture report with a little bit of fluid. With biochemistry, you may get away with 5 ml, 10 ml. But with cytology, they have to spin the fluid down. You know, they really spin the fluid down and don't look at the serum, but they look at what is settled down. And more fluid that you send, better the chance. So the recommendation of the microbiology, recommendation of the lab is that you must send at least 40 ml. So 2 tubes full of 20 ml each for cytology. And then another 10 ml for microbiology and some for the biochemistry. So 3 tests that you do. What about microbiology? You send it in your standard culture bottle and that's all right. But nowadays, there are many, many studies which have looked at the use of a BACTET culture bottle. This is bacterial culture bottle, okay? BACTET is a short form for bacterial culture bottle. And these are the new culture bottles that are available in the market. And the advantage of the BACTET culture bottles is that they have shown an absolute increase of 21% more number of organisms, a proportional increase of 50%, but more importantly, in the BACTET culture for bottles, as compared to a standard culture bottle, they have found 4 additional organisms. So this was a large study that they looked at everything, and they found that very often by using a BACTET culture bottle, you can actually grow more organisms because the culture medium is more suitable for growth of a wide variety of organisms. So if you're asking the exam what culture bottle, you must use the word BACTEC, B-A-C-T-E-C, okay? And this helps you get better results and better answers. So management protocol. Let's look at how we manage empyemas, how we manage infected pleural effusions, okay? So there are 2 guidelines out there in the market. You must know this. One is the BTS guideline and one is the American College of Chest Physician guideline. These are the 2 various guidelines. Now, the reason why you need to know both is that the philosophy of the 2 guidelines is completely different in terms of management. Okay. So the BTS guidelines per se talks directly of treating the patient. And it talks of appropriate antibiotic use. It talks of sampling and analysis of pleural fluid. So everything that I've been talking so far has been from the BTS guidelines. It talks about early chest tube drainage. It talks about intrapleural fibrinolysis. Is it effective or not? And then it talks about referral for surgery. So BTS guidelines is completely sort of a clinical guideline which directly is looking at the patient and saying do ABC. Okay. This is the guideline, and I have already, I think, sent this to you. This is a beautiful flow chart which gives you very clearly what to do at what stage, how much fluid to send, where to send, and what to do if it comes back positive, negative, and things like that. So this I've already sent you. I want you to go through this and get a flow chart in your mind about how you will manage it. And I'll talk about this in detail in a minute, okay? As opposed to this clinical management, the ACCP guideline, the philosophy is completely different. What the ACCP guideline is doing is it is evaluating risk of various features for poor outcomes of the disease. Okay, so it is saying that if it's a very high risk patient and there is high chance of poor outcome, drain the fluid immediately before you do anything else. Then it's also talking about fibrinolysis and surgery as a therapy. But most important thing you've got to remember is that the ACCP guideline is based on level of evidence. And almost all the recommendations of the ACC guidelines are level C and level D. 60% are level C and 40% are level D. So really the evidence in Empyema at this moment is not very strong. So I'll talk about what you mean by evaluating risk, because you must be wondering what the hell are they talking about. So let's look at how ACCP guidelines talk about managing Empyema. So they divide Empyema into various stages. So we know this. There is an acute or a serious stage. There's a fibrinopurulent or an intermediate stage. And there's an organizing or a late stage. So that's the first point, that they talk about acute or serious stage. They talk about fibrinopurulent or intermediate stage. And they talk about organizing or late stage. And the factors which we discussed earlier come in the acute stage. Then you get this thick, opaque fluid and fluid with a positive culture. That's the second stage. And then, of course, the formation of the cortex. The way they are scoring these empyemas is there is something called a severity scoring of empyema. So every single factor that we spoke about, a fluid pH, a fluid glucose, chest X-ray, parenchymal entrapment, and anaerobic infection, all of these are given a point. And then depending upon the total score that you get, the disease is decided as mild, moderate, or severe. So this is something that you have to remember. So normally we are used to, acute stage, intermediate stage, and chronic stage. But this is different. Mild, moderate, and severe in the ACCP guideline is defined by the number of parameters that are positive in the findings. Okay, and that is the basis of an ACCP guideline. So it's a little more complicated, and it talks about treatment on the basis of risk factors. Okay, so here we are going through that same chart talking about the risk of poor outcome in patients with parapneumonic empyemas. So this is about the philosophy of the two guidelines. One is based on clinical practice, straight away, bang, 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 and there's a chart. And the other one is based upon risk of outcomes. And depending upon what is the risk of outcome, then you decide what is the next step of treatment. Okay, so antibiotics. Let's talk about the treatments now. Is it clear to everybody? Have you understood what I said about this ACCP guidelines, guys? Yeah? Okay. The philosophy is different. That's important for you to understand, okay? Because in the exam, they will ask you, why are you using this or why are you using that? Okay. Let's look at antibiotic use. The first and foremost statement, which the BTS guideline categorically states, is that no antibiotics should be given randomly or empirically. If you do have to give antibiotics, they should be based on sensitivity and culture. Okay? The recommendation is that at least 1 week of intravenous antibiotics should be given, followed by 2 weeks of oral therapy. Now, this is not what happens in India. In India, as soon as you have any suspicion of empyema or any infection for that matter, you will just start bang, 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 highest level of antibiotics, broadest spectrum. So you're really spreading the net wide. The problem with that is you have more risk of having antibiotic resistant organisms. And so that is why it's very important that we keep antibiotic treatment to the minimum, and it should be evidence-based. That means it should be based on the culture sensitivity. And treatment should be monitored on the basis of CRP, procalcitonin, and a chest X-ray. These are the 3 indicators for monitoring the treatment, okay? In India, we give for IV antibiotics for 2 weeks, followed by oral antibiotics for 4 weeks, and it's quite a prolonged treatment. I think the reason also is because there is a lot of cross-contamination in the Indian environment. So you start off with one organism, and unfortunately, already the organisms are so resistant to antibiotics that other colonies and opportunistic organisms get involved. And that is why treatment of empyema in India is quite a difficult scenario. So there are reasons why people go so broad spectrum. Okay. So that's the first step of management of empyema, antibiotics. The second step of management is that if the patient is symptomatic or if there is a good amount of effusion, more than 500 ml, then you drain the chest, okay? Because that will help the patient with symptomatic improvement. So what is the size of the chest tube? This is a big discussion, and a lot of people will ask you these questions. Now, there are at least 2 or 3 randomized control trials, one of them being from the Brompton, and there is a meta-analysis of these things. And all of them have said that the size of chest tube doesn't matter. In the old days, if the patient came to us, even now, if the patient comes to us, we put in a 28 French chest tube, okay? Because we are surgeons and we think it is thick pus and you drain it out, and, you know, big surgeons, big sizes, and that works. But now the evidence is showing that even if you put in a 12 French or a 14 French Seldinger drain, you still can have good clinical outcomes. You cannot sort of question. As surgeons, we are always hesitant about this sort of data. But if you look at the evidence, almost all the studies were randomized controlled trials. They weren't just some observation studies. So you have to take them on board. But also you got to realize that the size matters because of the thickness of the fluid. If you got frank pus coming out of the chest and you put in a 12 French drain, that's not going to work. And you'll end up having to flush the drain and cause more infection. So it depends on the clinical situation. And the other thing that matters in a chest tube is the presence or absence of loculation. Because loculations, you know, if there are multiloculated collection and you put in a 12 French drain in a single loculation, it's not going to help the patient. So in the presence of loculation or when there is thick pus, the recommendation is that, you know, send them on for surgery, because VATS is so effective these days with so minimal morbidity that you can very easily drain and get these guys quickly better and then continue antibiotics, because the treatment really is antibiotics. But the one point which every single paper has made is that no matter what size you put in, it has got to be image guided. Not the 28 French one, which we do surgically. There you don't really need image guided. But particularly when you're putting in a Seldinger drain, you must do it image guided. And that has become law now in the UK. And the presence of loculation, as I said, is probably an indication for referring the patient onto surgery. Because I know a lot of people will try and put in streptokinase and urokinase and all that stuff. And I'll talk about that in a minute. So intrapleural therapy. There is absolutely no role, absolutely no data supporting the use of intrapleural antibiotics. That's number one. So putting in a tube and then trying to flush it with antibiotics is a complete no-no. There is no data. All it does is it increase the risk of other infections, okay, and antibiotic resistance. So completely not the done thing. The second question is intrapleural fibrinolytics. Now, use of streptokinase and urokinase, which a lot of pulmonologists in India follow, is actually not indicated. The BTS guideline, in its very first line, it says that the use of intrapleural fibrinolytics, particularly streptokinase and urokinase, is not indicated, and the level of evidence is A. A is the highest level of evidence. So next time you see somebody using streptokinase or urokinase, you must just kick them on the backside and say, there is no evidence, and if any complication happens because of the streptokinase and it goes to court, there is no mercy in that. You will lose the case straight away. Most studies that looked at these things were uncontrolled and non-randomized. And a meta-analysis of all these studies did not show any benefit with intrapleural fibrinolytics over mortality or hospital stay. In fact, it causes more morbidity than benefit to the patient. Okay, so it's important to remember this. The only study of the use of intrapleural fibrinolytics is the Multicenter Interpleural Sepsis Trial 2. This is the latest trial. This is 2012, and this was a multicenter trial which did 4 groups. They categorized these patients into 4 groups. This was a double-blinded multicenter trial. Categorized the patient into intrapleural TPA. We're not talking about streptokinase or urokinase. They did one group with only TPA, one group with only DNAs, one group with placebo, and one group with a combination of TPA and DNAs. Okay, these were the 4 groups, and the finding of this trial suggests that there is some improvement in the group that has a combination therapy, TPAs plus DNAs. And there is suggestion that there is improved radiology, 4% less surgical referral. Now, my problem with this is, this study had only 210 patients, but it was a double blind randomized study. But 4% less surgical reference means 2 out of 48 patients did not need surgery or were not referred for surgery. So the numbers are pretty low, and to get a sensitivity result out of this and try to extrapolate it to the population at large is not a good science that you have to follow. And there was some evidence of reduction in hospital stay. But if you look at this, they did not compare this to surgery or VAT surgery. So VAT surgery can give you all these benefits: improve radiology, reduction in hospital stay, quicker recovery. So I think a better study would be all of this versus surgery. And that is what is needed to get good data out. Okay? All right. So we have done antibiotic prophylaxis. We've done chest drain. We have done intrapleural fibrinolytics. Now the only thing left for us to do is surgery. So what are the surgical managements of an empyema or an infected pleural space? So first and foremost, I'm going to name out the various surgeries that we can do. One is drainage of empyema and decortication. In my opinion, this is the gold standard surgery. To be really honest, nowadays, if you don't do drainage of empyema and decortication, I think you're doing a patient a disfavor. And in my particular practice, we are doing all of this by VATS and robotics. And so the morbidity and the mortality is very low, and the outcomes are very good. And we have presented this data with a sample size of about 842 patients. So it is not a small group that we are looking at. The other option available to you is a rib resection and window. Okay, so very septic patient, unfit for surgery. You need to just drain the sepsis out, take him to theater, quickly make a incision on the skin, chop off 2 ribs, get it out, and let the pus out. That's another way of doing it. I think somebody's just raised a hand to ask me a question. Is it very urgent, or should we wait till I finish? I saw somebody's hand raised. Who was it? Somebody wants to ask me a question? Okay, so we'll wait till the thing is over. Okay, all right. The third option which we have got is called as an Elozere flap. Okay, and I'll go through each one of this in a bit more detail. And the fourth option is a thoracoplasty. Okay, and we'll talk about each one of these. So let's look at the various options. So I'm going to start off with a VATS decortication, because in my opinion, this is a gold standard. And now with my data being out there, we have shown, and we have written this many, many times, that tuberculosis is not a contraindication to VATS decortication. Get this very clear. A lot of people say, oh, thick empyema, thick cortex, 2 millimeter, 5 millimeter, 10 millimeter. I know somebody in AIMS is doing a study on the thickness of the cortex. For us, I promise you that we have looked at all sorts of patients. A lot of people tell me, Naini, yours are all private practice patients. They are not people who have these very bad cortices. That's not true. We see all sorts of patients, and we are able to decorticate almost all of them. Okay. So what is the principle in VATS decortication? To get good results, you should not just attack that local cavity and the cortex. That's not the way to do it. You have to be very aggressive. You've got to not only take away the pus, not only take away that pocket of loculation, but you have to undo every single adhesion in the chest, remove it from the apex to the bottom, hilum to hilum. The complete lung must be free, so that every single alveoli that you can recruit will help the lung to re-expand and fill up the space. If you do only that little pocket and take the pus out and leave a drain and come out, I don't think you will get good results. You will end up with secondary infection and reinfection. So we are very aggressive. We completely release the whole lung from top to bottom. The most difficult portion is the apex of the lung, where it is stuck to the subclavian artery or brachial plexus outside. And the other difficult area is the diaphragm. And I'm usually never satisfied till I've taken the lung off the diaphragm and I have released the inferior pulmonary ligament. That is my criteria for completion of a decortication. I will always preferentially do a decortication for both the visceral pleura and the parietal pleura. But because I'm doing this by VATS, I will always do the parietal pleura first and the visceral pleura first and then the parietal pleura. The reason for that is because if you do the parietal pleura first, there's a lot of oozing and the blood drips into your field of vision and you can't see very well. So I prefer to do visceral first and then go on to the parietal and take it out. And the reason I do include the parietal pleura is because afterwards, if you leave the parietal pleura behind, it starts to shrink and it causes the chest wall to become more like a fibrothorax. And these are young patients with problems and you don't want them to have, fibrothorax and things like that in the future. So that's why we are very radical with it. I personally wash every single chest with 1 liter of saline, with 100 ml of betadine, and about 20 to 30 ml of hydrogen peroxide. This I'm questioned quite a lot in every meeting when I present my data. People will stand up and say, oh my God, hydrogen peroxide in the chest. I don't think it's a problem. I have used it in 1,000+ patients and we presented this in ISMICS last year and the year before that as well, somewhere else. And we have had 1 or maybe 2 patients in whom we got an anaphylactic reaction, which we treated with appropriate, antihistaminics and steroids. So really, the advantage of hydrogen peroxide is twofold. Number one, it disintegrates into H2O and nascent oxygen. The nascent oxygen will attack the anaerobic bacteria. That's one. Number two, it's an exothermic reaction. The exothermic reaction creates heat, and the heat allows the surface of the lung, which is oozing blood, to coagulate. So when you wash out with betadine and hydrogen peroxide, you actually cause local hemostasis on the surface of the lung, and that is what prevents the onset of hemothorax in these cases. In my personal series, we've had maybe 2 who have needed re-exploration for bleeding following a decortication. I will always place a single drain under vision with draining both the apex and the base. So I'll make an extra hole at the base, but always make sure that the hole should be made on the radiography line so that it can be seen on a chest x-ray, the radiolucent line. And number 2, don't make it too low because it will come out and lie in the subcutaneous tissue, and that's not very good. All my drains are connected to medulla suction device, absolutely mandatory. I will connect all my drains to medulla suction device to allow the lung to re-expand and fill up the space. So I'll put in one port first, a camera goes next to the port, and then I will dissect till I get my second port in. Then my peanut goes into the second port, and I will dissect till I've come to the diaphragm and make my third port. Now watch, I'm doing the whole operation exactly like you would do in an open surgery. So here I am actually peeling the whole cortex off the surface of the lung. And the trick in this operation is to find the correct plane. In this particular patient, it's coming off quite nicely. But in a lot of patients, it will be very difficult to find the plane. So this is like peeling an orange. Sometimes some oranges are very good and they come off very well. But in some oranges, the cortex is very thick and stuck to the surface of the lung. In that scenario, what you have to do is get into a subpleural space. and try to peel it off. Don't just leave things behind. Very rarely, if I find that the cortex is very badly adherent to the chest and will not come off, I will make multiple cruciate incisions with a knife and allow the lung to re-expand. And very often, while doing the decortication, I will hold the cortex and pull it up and ask the anesthetist to re-inflate the lung. So while I am pulling the cortex, the anesthetist is the one who is doing the decortication of the lung. So it's a combined thing. So the decortication, when the anesthetist re-inflates, one, it allows that lung to peel away from the cortex. And number two, more importantly, because the lung is a low pressure circuit, when you re-inflate it, the bleeding stops. Okay, all that oozing that is happening from the surface of the lung starts to disappear once the lung starts to re-inflate. So I always will re-inflate. I don't wash out in the middle of my decortication. I will always wash out at the end of the decortication. So there are tricks that you have to use to make it better. So all tissues sent for culture and sensitivity. Always, always, always send it for histopathology. Nikhil is presenting a paper. I don't know how many patients he's talking about, but I can distinctly remember at least 6, 7, or 8 patients whose histology came back as malignancy. So we went in thinking we were dealing with empyema. We thought this was tuberculosis, and the histology came back as empyema, came back as malignancy. A couple of them were mesothelioma. Some of them were metastatic adenocarcinoma. So it's very important to send the tissue off for histopathology. You must send it also for ADA and TB PCR, particularly when you are thinking that this could be tuberculosis, and sensitivity and culture will help you to guide your treatment of the TB in the future. Now, in my institution, we are very aggressive with postoperative physiotherapy. In fact, we have a department of integrative medicine, and I am very much involved with them, and we do pre and postoperative yoga breathing exercises for all these patients. So my yoga therapist will teach them preoperatively yoga exercises, and within 4 hours following the surgery, he will be back, whether the patient is in the ICU or recovery or wherever. He will get the patient out of bed, get them to do the deep breathing exercises, and this is what has helped us to really get good results in our patient. Obviously, the treatment of tuberculosis is anti-tuberculous therapy, and that is guided by the pulmonologist. And most important is nutritional support, because these guys are usually nutritionally depleted, and it's very important to help them, to get a dietitian to see them and support them with good nutritional intake. So this is the way we do it. This is my therapist who comes with me on my ward round, and all patients will get this. They will get meditation, they will get anulom, vilom, they'll get pranayam, they'll get deep breathing exercises, they'll get this thing, I think this is called a shitkari, where essentially what you're doing is applying PEEP to the airway. So what all of this does is it allows the lung to re-expand, and the key to the success of the surgery is that the lung should re-expand, fill up the space, and you continue the treatment afterwards with medical therapy. Very often people ask me, what about air leak? Are you worried about air leak? To be really honest, my philosophy is completely the opposite. Initially, when I started, I was worried that if I'm going to try and decorticate, I will get more air leak. But with time and with experience, I realized that the more you release the lung and you allow the lung to expand and fill and touch the chest wall, more the chances of pleurodesis. So air leak only stops with good pleurodesis, and that is why we are very aggressive and we really push the patient very hard with postoperative physiotherapy. I also use digital suction device to allow the lung to come up to the chest wall and stick it to the chest wall. In Medanta, we are very fortunate to have a Ayurveda garden on the 5th floor of the hospital. And most of my patients, at least when I was regularly coming to Medanta, most of my patients would actually next morning be seen walking in this garden as a part of therapy. In fact, we would prescribe it for the patient, because this is a security area and nobody is allowed to go until and unless there is a prescription from the doctor. With the integrative medicine, we also use a lot of therapies in the follow-up period when people come with chronic pain or discomfort from the wounds, and we use these little massages and oil massages and potleys. And I don't know what works for these patients, to be really honest. Is it the therapist's talk, or is it the hot fomentation, or is it the drugs or the medication that they are using? But whatever it is, it seems to be making a huge impact to the outcome of these patients. So much so that we have actually published an article in the Journal of Thoracic Surgery talking about an integration of robotic surgery and Ayurveda. And now the NHS has actually asked me, and the WHO is asked me to get involved with trying to roll out integrative programs across the UK and in other countries as well. China is asking about the use of Tai Chi, which is their local exercise program with thoracic surgery. Canada is talking about it. US is talking. So a lot of people are showing an interest in this sort of thing. So this is the sort of X-ray that you get. This is a pre-op X-ray with a loculated empyema. Immediately post-op, the X-ray looks horrible. It looks worse than before. Don't worry about it. If you have done a decortication, and if the lung is completely expanded and there is no air leak, the drain can come out. And don't worry about the radiology, because the radiology takes at least 6 weeks to 3 months to start becoming better. And if you see them in the follow-up, it starts improving better and better and better. So don't worry about the radiology. Be confident about the surgery that you have done. Okay. So now talking about a window. Okay. So let's talk about a window. This is a procedure that is done in sick patients who cannot tolerate surgery. Also done in India particularly. I think in your TB hospital, it's quite a regularly followed procedure, because there is so much of patients coming in with these problems and fewer slots available for surgery. Hence, to get them over this period, a lot of rib resection and windows are done. I personally do not do rib resection and windows until and unless the patient is unfit for surgery, because there's a lot of morbidity associated with this. But Dr. Diwan and Dr. Sri Krishna and Dr. Rajan Santosham have actually shown very, very, very good results with the use of a window thoracostomy for treatment of empyema. So a rib resection is where you make an incision, you get into the most dependent part of the chest, cut a piece of rib and leave a nice drain in. That's a rib resection and drainage. Elozor flap is when you add a flap to keep that rib space open. Okay, and I'll show you how an Elozor flap is done. So this is your infected space. You get in there and you make a flap like this. It's usually the most dependent area of the lung towards the diaphragm. A U-shaped flap is made. You cut off the ribs in 2 positions, okay, and take away this piece of rib in the middle, and then invert the flap inside so that the window does not close. So you have to make a flap and invert it. So see here, the edges are sutured to the inside of that wound so that there is epithelialization. The skin turns inward and then this wound will not close. So this is how it looks like. So this is a skin turning inward to the edge of the skin, and here is a skin, the flap going inside, and then this allows A, the pus to go out, and B, because it allows free drainage, immediately the patient starts to feel better and the sepsis starts to improve. But of course it takes a long time to heal, and the patient has to continue with his antituberculous therapy. Very often these patients are then referred to me for closure of these windows. Now this young female who is actually a doctor, she was a medical student when she got infection in the chest, and God knows one thing led to another, things went wrong. She had one surgery followed by another surgery followed by a third surgery, eventually a pneumonectomy, and eventually this this LOCR flap in a window. And for 5 years of her MBBS, she went through with this thing with pus pouring out of her chest and huge amount of excoriation around all of this. And she came and met me and she said, her father and mother said, listen, our daughter has to get married now. She's just got into MD medicine. We really want you to look into closing this window. And at Medanta, I'm very, very fortunate to work with a good plastic surgery team. And we've done about 14 or 15 of these cases now where we have actually attempted to close this window. And the therapy is that you go in there, make a nice thoracotomy, clean everything out. You have to resect all the unhealthy tissue. You might even have to actually do a lung resection if there is an infected lung there. Sometimes you have to put in a muscle flap to cover the bronchopulmonary fistula that you may find. And then you get into the abdomen and get some good amount of omentum. Omentum is a beautiful tissue because it's really very well vascularized, and you can pedicalize it. You can make it into a pedicle and reach right up to the top of the chest. And we take it from the abdomen and then swing it through a tunnel into the chest. So here it is. We have first opened up, debrided everything, turned the patient onto the back, did a laparotomy, or sometimes we also do it with laparoscopy. Then they get the whole pedicle, push it into a tunnel into the left side, and then turn the patient back. So it's quite a cumbersome surgery. But here we are putting the omentum, and to one side, whatever leftover muscle we could find. And that's why I always involve the plastic surgeon, because they are 10 times better than me at finding flaps and at trying to salvage muscle and trying to salvage the vascularity. A lot of thoracic surgeons are hesitant to invite other people into their theaters. But I tell you, we have, whatever cases we have done as joint cases, we've had 100% results. None of these guys have come back with a complication. And the reason for that is because super specialist people are doing what they are good at. This is that same young lady, and I was very fortunate to know that, very happy to know that she actually is soon to complete her MD anesthesia and probably will be getting married. Sometimes in empyemas, you will see these sort of sinuses on the chest wall. You may see 1, you may see 2, you may see 3. This guy had multiple sinuses. He's had multiple surgeries. In fact, even has had a thoracoplasty, but these sinuses keep coming back. Now, the trick to this is that you have to track the sinus all the way into the chest, and it has got to be a radical debridement of all infective tissue. So we did what is called as a sinogram. That means you inject it and do a CT. And at the same time, we also did a WBC scan to see for any infective tissue anywhere in the chest. And we went back in and again did exactly the same. We did a radical resection of all infected tissue. I took out the first rib. I also took out the 8th and 9th rib. And I remember I took out some piece of the lung as well in this patient and completely cleaned it out. And then we got the plastics to put in the omentum. Obviously, this guy has had about 3 or 4 thoracic operations on the same side. And we saw him about 3 years down the road, and these sinuses have not come back. So the trick to this is being very aggressive and really to debride everything completely. And this guy is actually a owner of a women's college in Ludhiana, and is a very, very big shot guy. And he's very grateful to us for having done what we've done to him. So the last option that we have got left over is thoracoplasty. Now, Dr. Rajan has got a beautiful video on thoracoplasty where he talks about the technique. Unfortunately, I couldn't call him today, so I cannot show the video because I don't have his permission for it. But he's got a beautiful video showing thoracoplasty. So let me show you how we do a thoracoplasty. A large incision on the chest wall, cutting through all the muscles and dissecting between the scapula and the chest wall, okay? Going as high as possible and as low as possible. And then the aim is to do a subperiosteal resection of the rib all the way anteriorly to the costochondral junction and posteriorly up to the transverse process. So you really got to take out the whole thing. And the philosophy is that you do multiple levels of thoracoplasty so that the thick fibrous tissue collapses down and fills up the space. So I'll just show you, this is what you want to achieve. You want to fill up the space. So if the mountain won't come to Muhammad, Muhammad will go to the mountain. That is the way we describe this. So you get the chest wall to drop down and fill up that space. And Rajan and even Dr. Diwan have got very good experience with this, and they have good outcomes. But these are reserved for cases as the last option in treatment of empyemas. Now, in my clinical practice, I have seen some difficult empyemas. Some of them are associated with tuberculosis, followed by aspergillomas, followed by empyema, and some of them are associated with ruptured hydatid cyst. So I just thought I'd quickly mention about management of these two. Ruptured hydatid cyst, I personally treat all of them, if possible, by VATS. Of course, we give them anti-helminthic therapy. The key to anti-helminthic therapy is it should not be more than 14 days treatment before surgery, because when you start giving them anti-helminthic therapy, the cyst has a risk of rupturing, and higher risk of rupture is when you go beyond the 2-week period. So the maximum amount of days before surgery is 14 days. That is the recommendation. And this I learned from A, literature, and B, I visited Tunisia. Professor, I forget his name, and he has done more than 600 cases of VATS resection of hydatid cyst. And he taught me his technique. And his technique includes getting into the chest and doing what is called as pleural prophylaxis. What I do for my decortications, that's exactly the same thing which we do for a hydatid cyst. I use betadine, hydrogen peroxide, and saline solution and leave it into the pleural cavity for 20 minutes. So what happens is the whole thing gets nicely washed out, and you do not wash it out. You just suck it out and leave the fluid in there, and then you do your surgery. So even if there is any further spillage, the scoliosis will come in touch with the hydrogen peroxide or the betadine and will die. Now, there are many scolicidal agents that people use, hypertonic saline and other things. I personally have had good outcomes with betadine and hydrogen peroxide, and I'm quite happy with it. If it's a small cyst, I will just incise it till the pericyst, and the anesthetist will gently inflate the lung to allow the cyst to be delivered in a bag. And then the cyst is aspirated in a bag and the bag is delivered out. So that way you can do this by VATS. In a large cyst, sometimes you may have to do lobectomy, but really the philosophy of management of hydatid is always try to conserve lung, okay, and that's quite important. This is Echinococcus granulosus. This is Echinococcus multilocularis. Echinococcus multilocularis is usually present in the Iranian, in the Afghanistan, all that sort of area. In our country and in the sub-Himalayan terrains, usually you get Echinococcus granulosus, which is a single cyst. In these patients, sometimes you might end up with almost 100 plus cysts, which you've got to take out. Now, a little word about aspergilloma. I personally do these surgeries by VATS. I prefer to do them by VATS and robotics. In fact, I have the largest series of this by robotics, because robotics, A, gives you a very good view, and all these dense adhesions can be tackled under vision so that you don't get massive bleeding from the chest wall. These patients, I'll give them preoperatively voriconazole for at least 2 weeks. Postoperatively, I continue the voriconazole for 3 months, okay? I always will optimize them medically before I take them up surgery, and if possible, try to push the ATT to completion before you do anything for the aspergilloma surgery. Now, the key thing in this surgery is to prevent spillage of the aspergilloma into the normal lung. So most of the times we will do the intubation with the patient lateral. So if it is a right upper lobe, I will put in the tube into the left side, but the patient's right side will be down, because these cavities always have endobronchial communications. And because they have endobronchial communications, there is a risk that there could be spillage of the aspergilloma into the normal lung. So we will do it with the patient lateral, double lumen intubation, and we will always insert a Fogarty into the remaining normal lung. So for example, I'm doing a right upper lobe aspergilloma. The tube will isolate the left lung. Endotracheal tube will isolate the left lung. But through the other cavity, I'll put in a Fogarty catheter into the bronchus intermedius. And that way, when I'm manipulating the aspergilloma, and even if there is spillage, it will not go into the middle and the lower lobe of the affected side. But important is when you are about to staple the bronchus, you must tell the anesthetist to pull back the Fogarty catheter. Otherwise, you'll inadvertently staple it along with your bronchus. You've got to be important. It's quite important that you remember that. Now, I personally do, as I said, my robotic lobectomies with for aspergilloma by the robotic technique. I leave the adhesions intact. I will try and get into the hilum. So the adhesions actually hold the lung up nicely and they allow you to work in the fissure and the hilum. And so my first trick is not to tackle the adhesions straight away. The adhesions are only done enough so that you can get into the hilum. Once you've got into the hilum and you've docked your robot into the right and the left side, then your instrumentation will help you dissect the structures out. And you can see that the view is very nice and very beautiful and under control. These are horrible surgeries by open technique because you cannot see and you make sweeping movements with your hand and you cause a lot of bleeding because there is a lot of neovascularization with these tumors, with these aspergillomas. So I personally use the robotic platform for these surgeries. And look how cleanly you can dissect everything nicely. It takes more time. It's not a surgery that you can rush through. But if you do it nicely and slowly, every single structure can be nicely dissected. And then once you have dissected these structures, then the next thing is the chest wall. And then you'll end up with a lot of adhesions on the chest wall. So doing the lobectomy is 1.5 to 2 hours, but dissecting it off the chest wall is a further 2 hours. But look at the robot, how well it can go at the apex and take it all out. So I personally love to do these surgeries by robotics. So that's the bottom line. These are very, very complex surgeries. They are very difficult surgeries. TV surgery is not a walk in the park. And I certainly have paid the price for it. Thank you very much, guys. Okay. All right. Are you guys still with me or you're sleeping? Okay, questions?
One question.
Hang on. Okay, you can now put your videos on and you can put your mics on and we'll have some discussion. Okay? All right. Who is this? Who's asking me the question? Identify yourself and tell me.
This is Andre.
Andre. Yeah, tell me, Andre. First thing first, did it make sense what I said?
It did.
Yeah, Andre, talk.
Is it safe to conclude that every paranpneumonic or synpneumonic effusion, where clinically there is a clinically and radiologically the patient is evolving a non-complicated pneumonia, if there is an effusion, no matter how small, it should be aspirated because almost half of them, maybe at least that much will go on to develop empyema. Is that statement true? That like pH less?
No, that's incorrect. The aspiration, if it is done, is for diagnostic purposes. So very often, just simple antibiotic treatment will actually take care of the infection. So if the patient is asymptomatic and there's a small effusion, less than 500 ml, I would not bother aspirating it. If anything, pulmonologists usually aspirate it for culture. But large effusions, or if it's a symptomatic patient, then it is worth aspirating.
Is the outcome any better in children? Like less number of
Yes. Children respond much better to therapy than adults, and they have much less complications. So again, in children, I offer VATS decortication or drainage, and in children, the technique changes slightly because there is an issue of isolation of the lung. So the philosophy, that question you will be asked in the exam in a pediatric, how will you do VATS or how will you isolate the lung? So the answer to that is the smallest size of a double lumen tube that is available is size 26, size 26 French. That works very well for a patient of about 11, 12 years old. Okay. Anybody who is less than that size or of shorter height, then you have a couple of techniques available. One is you do a single lumen intubation of the trachea and then put in a bronchial blocker into the opposite side, into the same side that you're operating. That's one way to do it. The second way to do it is particularly in a much more smaller child, because bronchial blockers cannot be put in children less than 2 years. So in that sort of a situation, you actually push the tube to the non-affected side. So if I want to operate on the right side, I'll push the tube into the left side and I'll operate on the right side. Another change in strategy is that I will, in a child, when I'm doing VAT surgery, I will preferentially want to use CO2, because the lung, you cannot aspirate the lung out. Like, it doesn't collapse as well. So the CO2 helps to push the lung away from your camera, then you can continue to operate. So these are the three strategies. One, 26 French tube up to age 11 or 12. Number two, a bronchial blocker between age 2 to 12. And number three is pushing the tube to the normal side so that the right side is isolated. And outcomes are very good with Empyema in children. Very good outcomes. Next. I have lost one child. In all these years that I did, I lost one child because he had an aspergilloma in the right lower lobe. And as he had a little niggling cough, and I think he had an endobronchial communication. While he was awake, everything was fine. His cough reflex was good, so it did not allow spillage. But the moment he went under anesthesia, he lost the cough reflex. And because he lost the cough reflex, the whole aspergilloma spilled endobronchially onto the other side. So even before we had started surgery or whatever, as soon as he went under and they started to tube him, he just collapsed respiratory wise. And then we found that the whole thing, when they sucked out the airway, they found the whole bloody aspergilloma had gone over to the left side. So as in, we were contemplating whether should we really operate or not. But then the consensus was that there is no other way out. He will never come out of the OT table if we don't take away the source of sepsis. So we took away the source of sepsis. We operated on him. But unfortunately, he deteriorated quite badly because he got severe systemic fungal sepsis and he died. That was my one loss of life in a pediatric group. Others have done very well. Next.
Sir, another quick question. You said you put just one tube that drains both the air and fluid, apex and base. There are separate holes. My question is if significant air leak has happened during your decortication,
you can put in two tubes if you want. You can put in two tubes. That's not a problem.
Right, sir.
It's a personal preference. Personal preference. You can put in two tubes. I know somebody who puts in two, three. It doesn't matter. It's a personal preference. The only time I put in two tubes is when I've got oozing and I expect the patient to collect a clot in the chest. That's when I put in two tubes. In a normal empyema with air leak is not an issue with me, because I know that if I apply good suction and I've done a good decortication, the lung will re-expand and stick to the chest wall. So I use a single drain, but you can put in two. In an exam, if an examiner is insisting that putting in a single tube is wrong and that's too much, just step back and say two tubes are fine. There's nothing wrong with that. So there's no data which has said that two tubes is better than one tube or one tube causes less pain than two tubes, to be really honest. There is no data. There is no comparative randomized trial which has shown a benefit of one tube over two tubes. The only reason I do one tube is because it's easy to just take it out next day and or in 2, 3, 4 days time and just get on with it. When you've got two tubes, all the time you'll find fiddling around, and then people take out one tube and then they don't know which one to take out and they take out the wrong one, and it's all a mess. So I try to keep it simple for the rest of the team to follow protocols. But there is nothing wrong with putting two tubes.
Do you still put on suction if there is air leak?
I personally always use suction. I am a believer in suction. I'm a
How much?
believer in suction. -2 kilopascals. -2 kilopascal on the topaz, and I always want topaz because topaz really, in my opinion, allows the lung to come up to the chest. My team has had a couple of problems now recently with the new topazes, where they've had blockages and no alarms and things like that. So they've moved on to using Atmos. But I use topaz, and in Barts in London as well, we bought 10 topazes last month. I'm still a believer of topaz. But you can say Atmos as well, it's not a problem. But then the same thing you've got to remember, that suction is a double-edged sword. So on the one hand, the suction will allow the lung to come up to the chest wall and cause pleurodesis. But the same suction, if kept for a prolonged time, will keep an air leak patent. It will start sucking. So my philosophy with suction is 48 hours you try with suction and see how it goes. Most of the times your lung will come up and the air leak will stop. If after that the suction still continue, the air leak still continues, then I will stop the suction and put them on a non-dependent, or I also use flutter valves. I'm very, very quick. Within 3 days following surgery, I'll attach it to a flutter bag if he can tolerate it. And I don't use that traditional Heimlich's valve. I use a non-return bag, urinary bag. In India, the simple non-return urinary bag, which has got a valve inside like a flutter. Only thing you've got to make sure is you cut off that the closure thing, because accidentally if they close it, then you become a tension pneumothorax. So I will physically cut it off and connect the thing so that it comes out. And with flutter valves, you can send them home. In the UK, we very aggressively send, even in India, we send them home with the drain and a flutter valve and a little band-aid which ties it around the neck, and they can wear their shirt on top of it. And they come back in the clinic 3, 4, 5 days later, and we repeat an X-ray. We clamp the drain. We do an X-ray when they come in. Then we clamp the drain, wait for 2 hours. But the important thing is they must wait in an area of observation, which means if they go into tension pneumothorax or anything, somebody is there to release that clamp. And then 2 hours later, we repeat the chest X-ray. And if the X-ray is the same as the one before, I will take the drain out. That's my philosophy with flutter valves. This is a question asked in the exam. How do you manage flutter valves? When do you put flutter valves? And how do you manage flutter valves? Okay. So it's a good question, actually. This is asked in the exam.
Just like for us who are not familiar with flutter valves, I mean, it's just to prevent backflow of the contents from the bag to the patient?
No, the flutter valve is to prevent the air from going back, not the fluid. It's the air that you don't want to go back. It's a one-way valve. So the air comes out, fluid comes out. The fluid, it doesn't matter whether it goes back or not. It's really the air that you don't want going back into the chest. So the flutter valve prevents the air from going back more than the fluid. Okay. So it's really an air leak problem that you're trying to solve. So it has got a low pressure. If you look at the pressure in an intercostal bottle, that column of water creates a large pressure. So the air has to really overcome that column of water to come out as a bubble. You understand that philosophy? So in a flutter valve, there is no column of water. So there is the pressure against which the air is coming out is very low. So it comes out preferentially and comes out by that route. And so the lung re-expands. It's not an immediate process. It's a slow process. It takes 2-3 days for the thing to come out. That's why a flutter bag is better than a bottle. Next. Anybody else?
Sir, this is Srinivas here.
Yes, Srinivas. Which institution?
Sir, I'm from Gangaram, sir.
Yeah, hi. Hi, Srinivas.
Hi, sir. So I wanted to ask, you do a VATS decortication, you do a visceral pleurectomy.
Do you do a visceral pleurectomy? Yeah.
I mean, you remove the cortex, sir. You remove the cortex completely.
Yeah.
And then you ask the anesthetist to expand the lung.
Yeah, I don't ask them to expand the lung after I've removed the cortex. When I start removing the cortex, after I've made an incision on the cortex, I will hold the cortex and a peanut in the other hand pushes the lung, and then the anesthetist re-expands the lung. So while I'm doing the VATS decortication, the anesthetist will re-expand the lung. Sorry, go on.
So in case the lung, in case the lung doesn't expand, what is your policy?
Number one is you do a bronchoscopy. That's the first thing you do. You do a bronchoscopy and get them to suck all that secretions out, and because then the problem is an endobronchial, something is blocking the thing. Then the third policy and last situation is when the whole lung is fibrotic and it won't come up. Then you are in deep shit. That is the worst.
Would you do a window, sir? Would you do a window in that situation?
I personally have never had to do that. You could do that. Theoretically, yes. But I have never had to do that because I will do a bronchoscopy, I'll suction it all out, and I will leave in the chest drain and I'll put it on suction and pray like hell. Touch wood, I have not been in that situation where doing a lung resection is not the answer. Maybe doing a window is an answer, but actually I will give him a good chance. I will actually leave a drain in, come out, wait for 2, 3, 4, 5 days. I may even consider at that stage a thoracoplasty rather than a window.
All right, sir. And regarding the Topaz Medla.
Sorry? Next
the Medla suction device, sir.
Yeah.
We tend to use a higher level of suction up to -40, -50 maybe. And I think that helps the air leak stops faster. What do you think?
No, I think -2 is good. There is you must read Alexander Brunelli's paper on this.
All right.
Read Alexander Brunelli. He's written a lot on Medina digital suction device, and his recommendation is -2 kilopascal. That is the most physiologically tolerated by the body in regards to the intrapleural pressures. And to be really honest, in so many years of using Medila, maybe once or twice I have gone up to -3, -4. I usually manage everything -2. And if it's not manageable by -2, then suction is not the answer. You go off suction. Because I just told you that suction is a double-edged sword. It will allow the lung to come up, or it will actually keep that air leak patent. So that it's a very, these are difficult decisions you have to take on the spot. I don't go up to -4, -5, to be honest. If it's not going to work, it's not going to work. That's the reality. Yeah, 2 participants.
Thank you, sir.
Who's that? Srinivas Manjunath. Manjunath's iPad.
Yes.
Hi Manjunath,
Sir,
how are you? From AIMS. How are you, my friend?
I'm fine, sir. How are you?
I'm all right.
So my question is, in TB Empyema, is there a minimum period of ATT after which you'll plan a surgery, or you would want to go at the first shot itself?
No, never at the first shot. In fact, I will defer the patient as much as possible. As much as possible. My minimum period between doing the surgery is 6 weeks at least.
At least 6
weeks. Better, but 6 weeks at least. I never ever do surgery at first shot. In fact, many patients have actually shown a resolution of the empyema by taking tuberculous therapy. So when you repeat the CT scan at 6 weeks or 8 weeks, they have started to feel better, they're eating well, the sepsis is controlled, and the CT scan shows a reduction in the size of that collection. So then you don't need to do the surgery. So I give them a good chance not to have the surgery. I don't think treatment of TB is surgical. I don't believe that. As a philosophy, I believe treatment of TB is medical. Surgery only facilitates the medicine. The reason why I advise decortication is 2 things. Number one, getting rid of the pus will make the patient feel better because the sepsis goes away. Number two, by taking away the cortex and the loculated collection of pus, you are allowing better penetration of the antituberculous drugs into the interpleural space. And number three, most of these patients, or a lot of these patients, are young people who are going to travel overseas and go abroad, and they don't want anything to be seen on the chest x-ray, not even a leftover little collection. So that's my indications for decortication.
Okay, so the second question is, what about these chronic empyemas, long-standing empyemas who present after 5 years, 6 years with minimal symptoms or maybe some symptoms? So what should we do about them?
If they are symptomatic only, you treat them, otherwise ignore them.
Okay.
I don't think you should treat everybody with a chest x-ray or a CT showing a collection. Let them have medical treatment. The treatment is medical. But to be really honest, the oldest decortication I have done is 12 years old. and the lung is such a forgiving organ. In a 12-year-old chest, after a cortex, the lung still came up. I don't know what it is about the lung. It's the most forgiving organ. The most unforgiving organ is the esophagus. We are in the domain of both the most forgiving and the most unforgiving.
Thank you.
Okay. Anybody else? Any questions? So does this, I want a little bit of feedback. We'll have 2 minutes of more conversation. I just want to know, does this sort of teaching help you? Does this interaction, is it interactive, or is it too long, or is it too boring? We could do 10-minute talk as well. I don't mind that. But I thought late evening, you guys are sitting at home. This might probably be a good way to reach out to you. Give me feedback while you're online with me. Just 1 or 2 points quickly. Anybody wants to give me a feedback?
Yes, sir.
Tell me, who's that?
Sir, this is Dr. Shashikaran from AIMS.
Okay. Tell me, Shashikaran, what do you think about?
Yeah, it's a really good initiative, sir. We are actually very lucky enough to be taught by you.
No. That's not the point. That's not the point. Shashikaran, what I want to know is this helping you?
It's good. It's really helping us. It's actually quite informative, and we are getting clinical tips that are more necessary for us in our regular clinical practice.
So it is something that we should continue. Is that what you're telling me?
Yeah.
Because if it is too long and very boring, I don't want to continue. That's the bottom line. So we should try and do this at least once or twice a week, at least, and more so for the people who are going for the FRCS examination. There are some of these guys who are going for FRCS. For them, I think this will be very important. Another suggestion to you guys, I'm going to make a suggestion to you guys, is during the week, I plan to put up some questions on our group. Okay, one question with multiple choice answers. And I want you to write these questions in your book and answer them. Okay, I'll tell you, there's a trick to recollection in the exam. The trick is that images work very well for the brain. That's the only way you recollect. That's why if you read a big textbook with lots of words in it, you cannot recollect in an exam. And the best image that you can recollect is your own handwriting. When you write something with your own pen and paper, your brain immediately locks onto it. And when you in an examination stressful situation, when somebody asks you the same question, you can actually recollect that page, and you can recollect what you wrote on there. So my suggestion to you is everybody buy a book, a notebook, and every single question on the top, don't fill it up with stuff. On the top of the page, just write the question, one question only per page, and write down 5 points. You only need 4 or 5 points. You don't need depth of knowledge. You need breadth of knowledge. It's very important. When in an exam, when I ask you a question, if you start talking, I know you know it. I will quickly go to the next question. So I don't want to know all the, what is happening at microscopic level. I want to know, do you know a little bit about this? So, I'll ask you a question. Name 5 immunotherapy agents. Today, if I ask you, you will not know it. You may not know the names of 5 immunotherapy agents. But the fact that I've raised this question with you, you will find out and write down 5 names. You don't need to know how it works, what is at a molecular level, but just 5 names of immunotherapy agents. Do you know what I mean? So keep doing that. Take a book, write down the question, write down 5 points about every single thing. Indications for metastatectomy in lung, 5 points. You know, indications for LVRS surgery. That way, if you write 4 or 5 points, it will stay with you in your mind and it will become very clear. Okay? By the way, I can just see, you guys don't know this, but my mentor actually is online with us. Dr. Booch, whatever I am today in life is because of Dr. Booch. And really, he's such a great man. He's actually so late in the night online listening to a conversation. He doesn't even practice thoracic surgery, but his quest for knowledge is so great that, you know, I think it's 12 o'clock or something, but he's there. So thank you, Dr. Booch. I just saw you on the group. Thank you very much. And I think all these students must thank you because it is you who has taught us how to teach people. All right, guys. Okay. Thank you very much, everybody. Shall we call it a day?
Yes.
I'm going to put this up online as well. Okay. Vinita, for you particularly, I'm going to give some questions for Viva.
Okay, sir.
You and the other 2 guys, make sure that you answer these questions. They are for the Viva. You will be asked in the Viva. So I'm going to put it up on the group, our group. And
okay.
you get these answers out there and try to answer them. Okay. And then in a day or so, I'll give you the answer out there. Okay. They're simple questions, but they are directed for the exam. So I'll give you one question with multiple choice below that, and you pick the correct answer. Okay?
Okay.
All right. Thank you very much, everybody.
Okay.